Hi all, here's some July updates. First of all, make sure you're doing your sign outs again, ideally within 30 minutes of the end of your shift. So far, I feel like things have been going fairly well. Obviously, there's been some crazy busy days where there's just no signing out because it's awful, but I think for the most part it's happening. Let me know if there's any glitches, anything that we want to do differently for flow purposes, if there's any, issues wrapping up patients or whatever. I want to know about it, or Amy wants to know about it, so let one of us know. But otherwise, I hope you're leaving on time. That is really important, and I don't want us all getting burnt out. Dr. Stewart sent me kind of a cheat sheet recently because we are underdiagnosing as a group acute respiratory failure. And there's some criteria that you can use for it. So I'm going to throw that up in the doc box. If you guys will watch for it and see if we can start diagnosing it more, as it will kind of help our morbidity, mortality, scores and whatnot to be diagnosing appropriately. PHI started a new flow for strokes. Basically, if you have a high suspicion for a stroke and you think that they're going to need transfer, you can actually call them at the onset, as you're getting your workup done, and they'll come without a destination yet, and they'll sit on the helipad and then wait for the destination to be determined. That's not to say you have to do anything differently than what you're doing. Going by ground is just fine. It's just for the sicker ones, if you anticipate needing PHI, you can activate their team before you have established a destination. So be what it may, maybe it'll help. Keep me posted. EMS has also developed some new protocols for transferring strokes from the field to try to get them down to the stroke center a little bit faster. And again, I think we'll just have to evaluate how that's going. The ED Collaborative Committee is a committee that meets monthly, and it's with ED nurses, techs, and then me. Anyone else is welcome to come. One of the things that came out is we are trying to decrease our length of stays, and obviously that's super hard when we're dependent on multiple other departments to be able to do our job, like radiology and lab. But the couple things that we do have control over is when you listen to ED efficiency studies, they really promote trying to discharge a patient. If they're ready to be discharged, you should prioritize that above everything else unless you have an actively dying patient, because without getting those discharges in a timely manner, it kind of grinds the department to a standstill, especially on those busy days. So make sure you're prioritizing those discharges as soon as you can. Another thing that I would like to encourage everyone to do is to make sure that you're MSCIing people as much as you're able to when you're out in RME. We're trying to, again, get labs and things done from the waiting room if at all possible. So if you're able to, when you're in RME, blow through the 4s and 5s, but if you can start MSCIing 3s, we want to see if we can make a difference there. The other thing that you're going to hopefully be seeing more often are the leads checking in. I know we talked about that at our corporate meeting, but they really should be doing it, and especially when things are starting to hit the fan, that's almost the time where you want to do it most, even though it's kind of hard to sit down for a second. But it's just those one last things, if they can get them done and then get your patient moving. Again, remembering to prioritize a discharge if it's at all possible. We are going to be short case managers over the next few weeks. Unfortunately, I'm sure you've already felt the pain of that. Radiology goals. I'm noticing that there's a couple of different problems with radiology. One of them is night reads being done, so that's a radiologist problem. But the department has an issue as well, in that they can easily get bogged down, they are short-staffed, their scanners go down, and so I'm working closely right now with administration, with their managers and directors, to try to find processes, when they're getting backed up, what trigger do we pull to make sure they're calling in their on-call people and that they're calling the director. And so I'll keep you posted on that as we start getting some traction with it, but keep me posted when you're having days where things are really backed up. Let me know. And earlier in the process, when you're like 4 or 5 or 6 behind, I'll let Thomas know, or you guys can let Thomas know, and then we start contacting their director and kind of pushing them right now. So it'll be interesting to see where this goes, but I really do want to make some headway because I know this is a big frustration for all of us. I don't want to speak for everyone, but I'm pretty sure it's all of us. There is the Bridge program is up and going. It is a state-funded entity for the next year. And hopefully thereafter we'll be able to get some funding for it. But basically it's like a social worker type person that helps our patients who have addiction issues. So that can be anywhere from opiate problems to alcohol to methamphetamines. She has homeless resources, all sorts of extra resources. So if there's any addiction patient that you have, go ahead and have the nurse put in a referral for the Bridge Navigator. And she apparently is very well plugged in with what the community can offer to help. So utilize that. I keep forgetting for all my alcohol withdrawal patients, don't forget. The other thing that we are asked to do, and it's come up a couple times recently for me, is go ahead and utilize telepsych. I had a patient the other day who was so depressed she couldn't get out of bed. She wasn't washing her hair anymore. And she didn't meet criteria for 5150, but also she couldn't get into a psychiatrist for like 8 more months or something ridiculous. And her primary wasn't prescribing antidepressants. They were like really not doing a great job there. So I got telepsych involved and they were super helpful. They're like, okay, start Wellbutrin at X, Y, and Z dose in 4 weeks. Either we'll evaluate her again or her primary can increase to this if she's not feeling better. And they gave really solid recommendations. So please utilize them because it's one of those things, if we don't use it, we'll lose it. But I really think it can be a helpful resource. Also, I utilized it for a patient who was really agitated and difficult to control. There was a disadvantage because it took several hours from the call back. But in any of those scenarios, give it a try. I would really encourage you to utilize the telepsych services. Another thing that came up, I would encourage you guys, if you have an open fracture of a long bone, orthos have been trying to send them out a little bit more, some orthos. I would encourage you to say, hey, I'd like to admit for ANSEF and admit to the hospitalist and kind of push it that way. We're trying to get some clarification from them as a service, but that's slow in moving. So I would really encourage you to have those conversations of like, well, it should probably be fixed in 24 hours. Why don't I put them in the hospital on ANSEF and you can see them in the morning? Let me know how that goes. If you get pushback, I really am interested in that. Otherwise, I think that's our updates. Hopefully this wasn't too long. If you have other stuff, please holler. I really do want to know what's up and where the struggles are. I'm working on it. Unfortunately, things move a little slowly sometimes, or a lot slowly. But I really care about all of you guys, and I want you to be working in an environment that you feel good about working in. So thank you for what you do. Take care.